Hi guys, good evening. Can you all see me? Can you all hear me? A quick feedback. Can you all see me? Can you all hear me? Quick feedback. Hi guys, good evening, good evening, good evening. Hi, so last week we spoke about the small bowel rotation, that is malrotations and midgut volvulus. Continuing on the same series, today as I have told you that we'll be continuing on the congenital disorders of the small bowel. Yes, so today I'll be discussing about two important topics. One, it is going to be your Meckel's diverticulum. Another one is Jejunal Atresia. So we'll kickstart the discussion with Jejunal Atresia. Just give me a second, guys. All right, chalo. Good evening, guys. Thank you. Thank you. Good evening. Namaste, beta. Chalo. So today's opening topic that we're talking about is going to be about the Jejunal Atresia. So when you talk about the word atresia, or whenever I say the word atresia, atresia basically means, if I have to simply emphasize, what does atresia means? It means basically incomplete. This is an incomplete or improper. It is an incomplete or improper channelization between two lumens. It's an incomplete or improper channelization between two lumens is what we call it as an atresia. And if it occurs at the site of jejunum, this will be called as jejunal atresia. This will be called as jejunal atresia. Now, in a normal course of development, you would see that in the foregut, you have the stomach. From there, you would have the duodenum until the second part. From here onwards, you will notice that you would have the rest of the parts. So I'll just continue across here. From the duodenum, it is where the jejunum would start. Let's say this is the jejunal limb that you have. And from the jejunal limb, you will have the ileum, and this is the ileal component. And this is the terminal ileum. The 60-40 ratio, we've already discussed it before. And then at the end of the terminal ileum, you have the appendix and the cecum, and you have the ascending colon, right? This is the basic objective that you have. Now, when you talk about jejunal atresia, we are concerned about that this part of the bowel lumen is not going to develop properly, right? So, based upon what is the extent, there are four different types of jejunal atresia. So, quickly discussing about what are the various types of jejunal atresia. What are the various types of jejunal atresia? What are the other different forms of jejunal atresia? So, divide the jejunal atresia into the following varieties. We have the type 1 variety, we have the type 2 variety, we have the type 3A variety, we have the type 3B variety, and the type 4 variety. And the type 4 variety. So there are four different varieties that you have. In the first variety of the jejunal atresia, if you take this as the lumen of the bowel, let's say if this is a lumen of the bowel, the entire bowel looks continuous. The entire bowel lumen looks continuous. The mesentery also remains intact. So where is the atresia? The atresia is inside the lumen. you will see either there are presence of these mucosal webs or there is going to be your tiny case, right? So it is going to be inside the lumen. So in a type 1 variety, when we talk about it, it is the mucosal web or the mucosal diaphragmatic type. This is what we call it as the mucosal web or the mucosal diaphragmatic type. This is your mucosal web or the mucosal diaphragmatic type or the mucosal. It is the mucosal diaphragmatic type. It is the mucosal web or the mucosal diaphragmatic type. In the type 2 variety, when you look across here, now this is where you have a pure atricial form. You will say this is the proximal end of the bowel. This is the distal end of the bowel. And both of them, they are not channelized, but you will see that they will be having mesenteric continuity. So you will notice that there is mesenteric continuity between the two ends of the bowel. This is what we call it as a type 2 variety. In a type 2 variety, both the ends, they have atresia, but the mesentery remains consistent. The mesentery remains consistent, right? So let's see what happens in a type 3A variety. I think most of you would have now already gotten the gist of it. In type 3A variety, you will see same thing. The bowel lumen will have an atresia. This is the atresic segment where the lumen of the bowel is here. You will also see there is a mesenteric defect also. Not only the bowel lumen, but also the mesentery is also having the defect. This is your 3A variety. Now 3B variety is going to be very typical because in a 3B variety, you can see in 3A variety, there is a mesenteric defect also. There is this mesenteric defect. There is this mesenteric defect in a 3A component as well. Now in a 3B component, you will see there is a complete separation of the two ends of the jejunal loop. So you will see that this is the proximal end of the jejunal loop. This is the ascending colon. This happens to be the cecum. This is your appendix and ileum and the distal end of the bowel loop. It is like this. Now, another interesting thing is you will see the entire mesentery is separated. So this has a separate mesentery and the proximal end and the distal end will have two separate mesenteric attachments. This is the proximal end. So this is the proximal end. This is the proximal end and this is the distal end. Now both the proximal and distal end has complete separation. So this is what we call it as the Christmas tree variety, right? So this is what we call it as the 3B variety is what we call it as the Christmas tree deformity. There are two different names. Either you can call it as an apple peel or a Christmas tree deformity. This is an apple peel or the Christmas tree deformity. Now the type 4 is the one that cannot be mistaken, where you have, you can look at the bowel loop. So there are multiple components. There are islands of jejunum and they will be held with a mesenteric component. They're held with the mesenteric component and you will see there are existing mesenteric defects also. This is what we call it as the sausage variety. This is what we call it as the sausage variety of the jejunal tree. This is what we call it as the sausage variety of the jejunal. This is the sausage variety of the jejunal atresia. So when you look at the entire component, there are five different types of the jejunal atresia divided into five different types, or I can say the five different components with four different numbers that we have given. Type 1, there is only mucosal web, or we also called as the diaphragmatic or mucosal diaphragmatic type. In type 2, there is atresia, but the mesentery is continuous, right? So I can just simply address it here that in type 2 variety, there is presence of atresia and the mesentery is continuous. The mesentery is continuous. In 3A variety, there is presence of atresia and there is mesenteric defect also. There is mesenteric defect also. In type 4 variety, this is what we call it as the sausage type, where you have multiple atresias, where you have multiple atresia with multiple mesenteric defect, with multiple mesenteric, there is multiple atresia with multiple mesenteric defect, with multiple mesenteric defect. So this is the entire component. This is the entire component of the jejunal atresia. So mota mota, when you look at the jejunal atresia, so there are the different varieties of jejunal atresia: the type 1 variety, the type 2 variety, the type 3A, type 3B, and the type 4 variety, right? So these are the entire components of your jejunal atresia, right? Now, just for the sake of understanding, if I have to give you a component, remember jejunal atresia. Jejunal atresia is the most common type. This is the most common type of bowel atresia. This is the most common type or overall most common type. This is an overall most common type of jejunal atresia, right? Guys, somebody is asking about the notes. Rushi, we do upload all our annotated PDF notes in our Telegram group as well as in our Meded group also. You can follow, as I have told you before and again, the group that you need to follow, it is called as the Surgery Guy. This is what we call it as, the group is the Surgery Guy. It is by my name, that is Dr. Sandeep Reddy. So this is both our Instagram as well as Telegram ID. So usually the notes are uploaded soon after the class on our Telegram group. It will be available. Notes are completed, beta. If you are feeling you are not getting the notes, I will re-upload all the notes today. Okay. We'll keep all the notes today. I will re-upload it. Yeah, I'll upload all the notes. Hello. Hi. Good evening, everyone. Chalo, let's continue as we are saying. तो जेजुनल एट्रीसिया का मोटा मोटा ये था कि जेजुनल एट्रीसिया क्या है. इट इज एन एट्रीसिया इन द जेजुनम दैट इज improper incomplete channelization of between two lumens. There are four different varieties of atresias that we have. पहले वैरायटी में सिर्फ म्यूकोजल वेब देखने को मिलेगा, मतलब अंदर से it is going to get obstructed, there is no flow, hence looking like atresia. टाइप 2 में आपको बावल में एट्रीसिया मिलेगा लेकिन मिसेंट्री में कंटिन्यूटी है. टाइप 3A में एट्रीसिया इन द बावल में एट्रीसिया इन द बावल प्रेजेंट है, उसके साथ मिसेंट्रिक डिफेक्ट भी प्रेजेंट है. 3B में क्या है, पूरा सेपरेट हो गया. 4 में क्या है, मल्टीपल डिफेक्ट्स हैं, दैट इज मल्टीपल एट्रिसिक सेगमेंट में मल्टीपल eccentric defect, and that is going to be type 4 variety. ठीक है, it is going to be type 4 variety. ठीक है. Now let's talk about the clinical features. Now when we talk about the clinical features of jejunal atresia, the usual age of presentation, it is going to be day 0 or day 1 of life, because it is an absolute obstruction. It's a frank obstruction. ठीक है. So on this, at this particular age group, what is the presentation of the baby? The mother is going to see the baby, or a pediatrician or a neonatologist going to see the baby, and the baby is now going to present to you with repeated episodes of vomiting. The baby is going to present you with repeated episodes of vomiting. The baby is going to present you with repeated episodes of vomiting. Now, when you look at this vomiting, it is going to be bilious in nature. So, this is going to be a bilious vomiting. So, on day 0 or day 1 of life, baby is now presented with repeated episodes of bilious vomiting. That's the only clinical presentation that you're going to see across here. Usually you will not see any other components here. The only associated congenital abnormality, right? So it is associated with the jejunal atresia is only associated one disorder, that is going to be your cystic fibrosis. That is going to be your cystic fibrosis, right? That's the only disorder that the jejunal atresia is associated with. Anyhow, I have a baby who is now presented with multiple episodes of bilious vomiting. The first investigation that I would like to do here would be of a plain X-ray. In a plain X-ray, I will find something called as a triple bubble sign. I'll say a characteristic triple bubble sign. I've already described it in the previous lecture also. Now, the minute I see this, to conclude the diagnosis, the investigation of choice is going to be the CCT abdomen. Now, once you get the diagnosis of jejunal atresia, the management is going to take the patient for immediate exploratory laparotomy, identify the type of atresia, and then perform jejunostomy. It is basically to anastomose two ends of the jejunum, and this is what we call it as jejunostomy. Right now, this is the basic outcome or the outlook of your jejunal atresia. But if you're a resident, right, and you're watching this, you would want to know something extra about jejunal atresia, and that I would like to tell you about the type 3B variety. Right, I'm going to talk about the type 3B variety. Now, in a type 3B variety, if you have tried to understand, this happens to be the esophagus, this happens to be the stomach, this is continuation of duodenum, and let's say this is the proximal end of the jejunum that is going. So the proximal end of the jejunum becomes atresia, right? Now the distal end of the jejunum, it is going to be present here. So this is where the distal end of the jejunum is there. Now this distal end of the jejunum is going to loop at this particular site. It is going to be continuous with that of the ileum, and entire the ileal loop is going to be present. And then obviously from here, you have the appendix, you have the cecum, and you have the ascending colon. So this is the component. You will notice that this end has a different mesentery, and because this is also a atresic segment, this end has its own mesenteric segment. So now you have two different mesenteric components. There are two different mesenteric components. This is one end of the bowel with a one set of mesentery, and this is another end of the bowel which is going to have another set of the mesentery, right? So this is your type 3 variety. In a type 3 variety, this is the proximal jejunal loop. This is the proximal jejunal loop, and this happens to be a distal jejunal loop. This happens to be a distal jejunal loop. Now, because it is completely separated into two different components, this is what we call it as the Christmas tree variety, or also called as the apple peel variety. Now, what is interesting for me is who is supplying the blood to the proximal end of the jejunal loop. You think it is the blood supply from the superior mesenteric artery, but which component of it? Now, very interesting when you look across here. I don't want to overburden you with information, but just for the sake of understanding, now when you look at the blood supply, this is the large bowel, right? Just for the, just stay with me. I don't want you to overburden. This is how the large bowel's blood supply would look like. This happens to be the cecum. This is the appendix, and this happens to be the terminal ileum, right? Now, when I say this is your superior mesenteric artery, which is present here. This is your superior mesenteric artery. This is present here. And there's an inferior mesenteric artery, which is here. I'm not worried about the inferior mesenteric artery. We'll talk about the superior mesenteric artery. The superior mesenteric artery will give rise to an ileocolic artery, which is going to give rise to the blood supply to the cecum. And at the same time, it also gives rise to the blood supply to the appendix. This is called as the appendicular artery. It also gives supplies to that of your terminal ileum. This is the ileocolic artery. Then you have the right colic artery, which is going to be present here. Then you have the middle colic artery. The middle colic artery are two branches, the right branch and the left branch, which is going to be continuous here. The inferior mesenteric artery will give rise to your left colic artery that is going to present here. It is going to give rise to the sigmoidal artery, and then also give rise to the superior rectal artery, which is present here. Now, we are not worried or concerned about these. This will talk in detail when you go into our large balls discussion. There's another vessel which is present, which is called as the marginal artery of Drummond, which is going to be continuous throughout the large ball. This is the marginal artery of Drummond that is present, to which these vessels, I mean, they are the one that is going to pierce the wall and then supply it, right? So this is the marginal artery of Drummond that is supplying the blood, to the entire bowel wall. That is supplying the bowel vessel to the entire bowel wall. There's another special blood vessel that is going to be communicating between these two ends, and this is what we call it as the arc of Riolan. Now, between the superior mesenteric artery and the inferior mesenteric artery, right? So, if I quickly give right, this is your superior mesenteric artery, this is your inferior mesenteric artery, this is your ileocolic artery, this happens to be your right colic artery, this is your middle colic artery, this is going to be into the right branch and the left branch. This is your left colic artery, this is your sigmoidal artery, this is your superior rectal artery. So these are the blood supplies. Okay. Now, when you look at this, or when you look at the entire coefficient of it, you see the ileocolic artery is going to supply onto the terminal ileum. But what happens in the jejunal atresia, that in type 3B variety, you will notice that if this is the superior mesenteric artery, the superior mesenteric artery, as I told you, will give rise to the ileocolic artery on one end and will give rise to the right colic artery on the other end. In this blood vessels, or I must say in this variety of jejunal atresia, you will see that there will be a retrograde blood supply to this limb, either from that of, either the blood supply is going to come from the ileocolic artery, or it is going to come from the right colic artery in a retrograde fashion. So the blood supply to the proximal end of the jejunum, either comes from the ileocolic artery or from the right colic artery, and they go in a reverse manner, and that is why it is more prone when you try to do anastomosis. If these vessels are cut, the vascularity is going to be lost and it will have very poor anastomosis. So if you are a resident and you are writing your competitive exam, the question that they ask you is, which among the following type has the poor prognosis on anastomosis? The answer is type 3B variety. It is associated with anastomotic. This is associated, or type 3B variety is associated with the anastomotic leak, or it is associated with that of the anastomotic stricture, right? It is associated with anastomotic stricture, or due to loss of vascularity. Yeah. What's jejunostomy? It is basically to anastomose two ends of the jejunum. So when I say jejunostomy, in a jejunostomy, what you do is, this is the esophagus, this is the stomach, this is the atricial segment. This is the atricial segment. That's the proximal end. The proximal end of jejunum. Proximal मतलब आगे वाला end, and this is the distal end of the jejunum. This is the distal end of jejunal mein. What I do is I'm going to make an opening here and I'm going to make an opening. After making an opening, I'm just going to suture these two ends, and suturing these two ends to make it continuous is what we call it as jejunostomy. This surgery, this surgery is what we call it as the jejunostomy. This is what we call it as the jejunostomy, right? So this is the whole concept of the jejunal atresia. This is the whole concept. This is the whole concept of jejunal atresia. Yeah, so far so good. Quick feedback. ठीक है. Aditya, it's happening soon. Probably just stay tuned. Another week or so. Chalo. So this is in the context of the jejunal atresia that you should be aware of. Okay. Now, another condition that is going to be quite important for us, it is going to be your Meckel's diverticulum. It is going to be the Meckel's diverticulum. So when I say the Meckel's diverticulum, now Meckel's diverticulum, before I even start discussing about it, this is the most common congenital disorder. This is the most common congenital disorder of small intestine. This is the most common congenital disorder of the small intestine. सर ब्लड सप्लाई रिपीट कर दो. अच्छा, ब्लड सप्लाई, चलो ठीक है. अगर आपको ब्लड सप्लाई और यू आर नॉट एबल टू अंडरस्टैंड, a quick recap on this. This is going to be your ascending colon. This is the hepatic flexure. This happens to be the transverse colon. This happens to be the splenic flexure. This happens to be the descending colon. This happens to be the sigmoid colon. This is going to be the rectum, and this is going to be the anal canal. Okay. This is the cecum. This is the appendix, and this happens to be your terminal ileum. ठीक है, ये आपका बावल का लूप है. ठीक है. फर्स्ट ईयर वाले भी एब्सोल्युटली देख सकते हैं बेटा. तो लेकिन सिर्फ एनाटॉमी वाला पार्ट, बाकी पार्ट आई थिंक यू विल हैव टफ टाइम अंडरस्टैंडिंग. लेकिन अगर आप फर्स्ट ईयर में हो, दिस इज क्वाइट इजी फॉर यू टू अंडरस्टैंड. ठीक है. तो दिस इज गोइंग टू बी योर असेंडिंग कोलन. This happens to be the cecum. This happens to be your terminal ileum. This happens to be your appendix. This happens to be your hepatic flexure. This happens to be your hepatic flexure. This happens to be your transverse colon. This happens to be your splenic flexure. This happens to be your descending colon. This happens to be your sigmoid colon. This happens to be your rectum. So ये तो इसका basic objective होगा. And dead in the center, you have the mesentery as well, right? Now, when you look at the blood supply, this is going to be your superior mesenteric artery. This blood vessel that we are addressing, this is your superior mesenteric artery. It is a superior mesenteric artery. So I'm going to talk about only the branches of superior mesenteric artery. Okay? So superior mesenteric artery के लिए, you will see there is a blood vessel that is going to run across the entire mesenteric border. Let's say at this particular site. Now this blood vessel which is running, this is what we call it as the marginal artery of Drummond. This is what we call it as the marginal artery of Drummond. ठीक है. अब ये जो marginal artery of Drummond है, this is the one which is going to supply the blood to the bowel wall. But who supplies the blood? But who supplies the blood to this marginal artery of Drummond? And that is what is our takeaway message. Okay, so we need to understand that who is giving the blood to the marginal artery of Drummond. The first blood vessel that you can see, it is going to be the ileocolic artery. The ileocolic artery give rise to the blood supply to the proximal end of the ascending colon. It gives rise the blood supply to that of the appendix. So the appendicular artery is going to be from here. And then it also supplies the blood to the terminal ileum, right? So the three principal supplies. It gives rise to the proximal end. This gives rise to the appendicular artery and also give rise to the blood supply to the terminal ileum. Blood supply to the terminal ileum. This is your ileocolic artery. This happens to be your ileocolic artery. Now, the appendicular artery is a branch of your ileocolic artery. The one that is supplying the appendix, the appendicular artery is here. Then you have the blood vessel, which is going to be here. Now, this is what we call it as the right colic artery. This is what we call it as the right colic artery. This is what we call it as the right colic artery. Then you have the middle colic artery, which splits into the right branch and to the left branch, right? So this is going to split into the right branch and to the left branch. This is your middle colic artery. This happens to be the middle colic artery. This is the right branch or the right middle colic artery. This happens to be your left middle artery, right? So these are all the branches. These are all the branches that you can see of your superior mesenteric artery. Okay? Okay. So this is the principal blood supply that it exists. Got it? So now going back to our Meckel's diverticulum, as I told you, it is the most common congenital disorder of the small intestine. If we say what is the pathophysiology behind it, what is the pathophysiology behind development of the Meckel's diverticulum? Meckel's diverticulum arises or it is formed. It is formed due to failure of complete regression of vitalo-intestinal duct. It is the complete regression of the vitalo-intestinal duct. In simple words, I can say Meckel's diverticulum is a remnant. It is a remnant. It's a remnant of vitalo-intestinal duct. Now, if you have already seen my lecture before on the development of the small bowel, I have told you very specifically that initially you will see there is presence of yolk sac. From the yolk sac, you see there is this vitalo-intestinal duct. The vitalo-intestinal duct is going to be at the junction between, this is the midgut that you have. So vitelo-intestinal duct will connect at the junction of the proximal and the distal end of the midgut. Okay. So this is where the midgut was getting developed, right? Now, as the midgut was developing, there are the cranial end and the caudal end. The junction between the cranial and the caudal end is where your vitelo-intestinal duct usually attaches. After the attachment, it pulls the entire bowel into the coelomic cavity and it usually disappears, right? So मोटा मोटा क्या है, ये आपका vitelo-intestinal duct है. Now this vitelo-intestinal duct, which is going to pull the bowel, this is where the mesenteric end is there, right? So I would say that the vitelo-intestinal duct faces the mesenteric surface of the bowel. The vitelo-intestinal duct, faces the mesenteric surface of the bowel and it pulls it in. Usually what happens is, once the bowel is completely developed, I have put it in a different context. One second. As the vitelo-intestinal duct is going to attach, I'll just rephrase this so that we understand it better. This is the cranial end of the midgut. This is the cranial end of the midgut, and this happens to be the caudal end of the midgut. The bowel is going to be pulled inwards, right? As it pulls inwards, you will see the attachment of the bowel to the mesentery is on the other surface, right? So you see the attachment of the bowel, to be very precise, the orientation to give you correct. This is how the attachment to the junction. So this is the cranial end, and this happens to be the caudal end, right? And this is where the mesenteric attachment is present, right? So this is where your mesenteric attachment is present. So the vitelo-intestinal duct attaches onto the anti-mesenteric border, not onto the mesenteric border. Okay, just to be on a clearer side. Okay. So the yolk sac is going to form the vitelo-intestinal duct. The vitelo-intestinal duct attaches to the bowel, and once the bowel or the midgut has been pulled inside, this usually disappears. In few patients, it has been found. That this vitelo-intestinal duct fails to regress completely. Now, once it fails to regress completely, at the antimesenteric surface, it forms like an outpouching, or it is left behind like an outpouching. It is left behind like outpouching. It is left behind like an outpouching. It is left behind like an outpouching, and this component which is left behind like an outpouching is what we call it as Meckel's diverticulum. So I can simply say it is a remnant. It is the remnant of vitelo-intestinal duct. This is a remnant of a vitelo-intestinal duct, and this remnant of a vitelo-intestinal duct is what we call it as Meckel's diverticulum. This is what we call it as the Meckel's diverticulum, right? Now, couple of important things about the Meckel's diverticulum, and then we'll dig more deeper into it. Now, one thing that you need to understand this, the diverticulum that is formed here, it is since birth. So I can say this is an example of a congenital diverticulum. So when I say congenital diverticulum, that means it is present since birth. Now, is it going to involve the entire wall or only the mucosa, submucosa? For example, like we spoke about the Zenker's diverticulum of the esophagus, which was a false diverticulum, right? Here, the entire thickness of the bowel wall is actually in the bowel, in the diverticulum itself. So this is an example of a true diverticulum. This is an example of a true diverticulum. Unlike in the acquired diverticulum, I cannot say it's a pulsion or traction, because here we are not talking about forces. Here it is a congenital deformity. So hence I cannot say pulsion, that is pulling, pulsion that is pushing, tractional that is pulling. It is not in that context. It is simply because of a developmental disorder So hence it is a congenital diverticulum. It's an example of a true diverticulum. It's a congenital diverticulum. Another very interesting thing is it is a mesenteric diverticulum. Also, it is an anti-mesenteric diverticulum. It is an anti-mesenteric diverticulum. This is a diverticulum that is formed on the anti-mesenteric border. So you can see this happens to be the mesenteric border. This is the mesenteric border, and this happens to be the anti-mesenteric border. This happens to be the anti-mesenteric border. Now, why I'm very keen on this is usually all the diverticulums are formed from an anatomical weakness in the bowel. If you remember in our anatomy lecture, I told you very specifically that the anatomical weakness is present on the mesenteric border, not on the anti-mesenteric border. So all the diverticulums are usually formed on the mesenteric border. Meckel's diverticulum is an exception which is forming on the anti-mesenteric diverticulum. So three important standalone points that we all should know: that it is an example of a congenital diverticulum. It is a true diverticulum. It is formed on the anti-mesenteric border. It is formed on the anti-mesenteric border, right? Now, there is a very famous rule that the Meckel's diverticulum follows, and that is what we call it as the rule of two. Now, in the rule of two, number one, it is 2 inches. That is approximately 5 centimeters in size. So it's quite big. It is going to be 2 feet, which is approximately 60 centimeters, proximal to IC junction, that is ileocolic junction. It is 2 feet, that is 60 centimeter proximal to the ileocolic junction. It is present in 2% of the population. So hence this is the most common small bowel congenital disorder. It is the most common small bowel congenital disorder. That is a 2% of the population. It consists of two different mucosa. It consists of two different mucosa. It can consist of ectopic gastric mucosa. It can consist of ectopic gastric mucosa, and because of it, it forms into peptic ulcer disease. It can also present to you with pancreatic mucosa or the pancreatic tissue, right? It can present with ectopic pancreatic. It can present to you with ectopic pancreatic tissue, right? So it is 2 inches in size, 2 feet proximal to IC junction, 2% of the population, and two different mucosa. It can consist of two different mucosa. Okay. So this is with respect to its rule of two presentation. It is with respect to its rule of two presentation. बेटा mesenteric artery तो mesenteric border से आएगी ना. The blood supply comes from the mesenteric border. You will notice the entire blood supply to the bowel comes from the mesenteric border, and then it supplies to the anti-mesenteric border. तो Meckel's diverticulum जो है वो anti-mesenteric border पे है, mesenteric border पे नहीं है, वो anti-mesenteric border पे. It is seen on the anti-mesenteric border. ठीक है. Now, remember in terms of clinical presentation, most of the patients with Meckel's diverticulum are asymptomatic. They're asymptomatic and they're usually an incidental finding. It is an incidental intraoperative finding. It's an incidental intraoperative finding. But when it gets complicated, then it starts presenting to you with symptoms. So I'm more interested in the complications associated with Meckel's diverticulum. What are the various complications associated with Meckel's diverticulum? What are the various complications? What are the various complications which are associated with that of the Meckel's diverticulum? The first one, it is going to be hemorrhage. It is associated with hemorrhage. It is associated with diverticulitis. It is associated with intersusception, or I can say intestinal obstruction. It is associated with intestinal obstruction. It is associated with that of chronic ulceration. And it is also associated with perforation. Associate perforation, perito, also associate perforation, peritonitis. So this is spectrum of the complications that you can see in association with that of the Meckel's diverticulum, right? The Meckel's diverticulum has a complication ranging all the way from the hemorrhage to that of the perfo. It can have hemorrhage, it can have diverticulitis, intestinal obstruction, chronic ulceration, as well as perfo, right? Now, when I say hemorrhage, now it is because of ectopic gastric mucosa. So when you talk about the hemorrhage, it is secondary to, or I can say it is due to ectopic gastric mucosa. Now this ectopic gastric mucosa which is present, this ectopic gastric mucosa will develop peptic ulcer disease. And this peptic ulcer disease is now going to present to you with painless, they're going to present to you painless dark rectal bleeding. It will present to you with painless dark rectal, right? So it's due to an ectopic gastric mucosa. It is causing a peptic ulcer disease and eventually resulting in painless dark rectal bleeding. In diverticulitis, because it is present in the right iliac fossa, the patient will present to you with right iliac fossa pain. It will be associated with right iliac fossa tenderness. Because of any bowel inflammation, all bowel inflammations are going to be associated with nausea as well as vomiting. It will be associated with inflammation, that it is going to have fever, and because of nausea, vomiting, there will be anorexia as well. Now forget about the diverticulitis. I say a patient is having a right iliac fossa pain, there's right iliac fossa tenderness, there's nausea, vomiting, anorexia as well as fever. The first thing that comes into your mind is your acute appendicitis. So hence the most common differential diagnosis is acute appendicitis. It is your acute appendicitis. The most common differential diagnosis, is acute appendicitis. That is why if a patient has features of appendicitis and if a surgeon is attempting to do an appendectomy and during the surgery if the appendix is normal, always trace the distal end, or I can say from there the proximal from the ileocecal junction you have to go at least behind 60 centimeters to look for the Meckel's diverticulum. How does it cause intestinal obstruction? Now remember Meckel's diverticulum. Meckel's diverticulum is considered to be the most common. It is the most common lead point in children. For intersusception. It is the most common lead point in children for intersusception, and hence intersusception will result in Intestinal obstruction. What is interception? It is when the proximal end of the bowel goes into distal end, blocks the bowel, and hence the content cannot move forward. We will talk about in our tomorrow's lecture about the bowel obstruction. In that, I will tell you in detail about all these components. For now, you remember Meckel's diverticulum is the most common lead point in children, resulting in interception, and that interception will result in bowel obstruction. It will result in bowel obstruction. So, in general, when I say what is an interception, this is how the bowel looks like. If I just divide them, this is the proximal end, this is the distal end. When the proximal end of the bowel telescopes into the distal end, that means when the proximal end of the bowel, it telescopes into the distal end. And when it goes into the distal end, this is where the proximal end of the bowel, this is the distal end of the bowel. It is going to go inside. It is blocking. It is clogging in. This condition is what we call it as interception. When the proximal end of the bowel goes into the distal end and it clogs it, this is what we call it as interception, and that is what is caused by Meckel's diverticulum. It is caused by your Meckel's diverticulum, right? Now, chronic ulceration is because of repeated diverticulitis. It is because of recurrent diverticulitis, which is untreated. Here the patient complains about recurrent periumbilical pain. It will present to you with recurrent periumbilical pain. It will present a recurrent periumbilical pain. And perforation, obviously, again, that diverticulitis can perforate, resulting in perforation peritonitis. It will result in perforation peritonitis. Okay. Now, when we talk about the Meckel's diverticulum, what are the various investigations that I can think about it? You can do an erect X-ray abdomen. If the patient has features of obstruction, if presented, with obstruction, you can also do ultrasound of the abdomen. USG abdomen, if the patient presents to you with pain or features of obstruction. You can also do a CCT abdomen for recurrent abdominal pain. But remember, the one that gives you an absolute picture, the investigation of choice is going to be a technetium 99 scan, because technetium 99 has got higher affinity for gastric type of mucosa. The technetium 99 got high affinity. This has got high affinity for gastric type of, it has got a high affinity for the gastric type of mucosa. So hence this is preferred, right? Now, if I say, if you have a patient with Meckel's diverticulum, which is complicated, how do you manage? Management for complicated Meckel's diverticulum, it is going to be limited bowel resection. It is your limited bowel resection with anastomosis, with primary anastomosis. So what do you mean by this limited bowel resection? Is if you have a patient who has the Meckel's diverticulum, and let's say this is the site, and let's say this is the site where the diverticulum is present. This is the site where the diverticulum present, and this is the mesenteric end. So when I say limited resection, I will take the end of the bowel loop where the diverticulum present, and I will excise this entire part, right? After excising this entire part, I will be left out with this end of the bowel. I'll be left out with this end of the bowel. And what I'll do is I will anastomose. And this is what we call it as the limited bowel resection with primary anastomosis. This is what we call it as the limited bowel resection with the primary anastomosis, right? Now, this is also called as the diverticulectomy with primary anastomosis. This limited bowel resection is also indicative of you are doing a diverticulectomy. You are excising it completely. We're doing a diverticulectomy. We're excising the entire diverticulum. Now, if you look at the whole context of it, currently, if you are a resident and you're also targeting your NEET PG or INICET or NEET SS, there is one thing that the examiners would want you to know, that what is the current indications. So what are the indications for surgery in incidentally found Meckel's diverticulum? Now this is the hot topic that they would want you to know. What are the current indications? What are the current indications for surgery in a patient of Meckel's diverticulum? The first one, incidentally found if the age is less than 50 years, if the patient is male sex, if the length of the diverticulum, is more than 2 centimeters, if there is presence of any ectopic tissue, and if there is presence of palpable, if there is any palpable abnormality, in diverticulum. If there any palpable abnormality in the diverticulum. So the current indications are age less than 50, being a male sex, length of the diverticulum more than 2 centimeters, presence of an ectopic gastric tissue, and a palpable abnormality on a diverticulum are the current indications for surgery in an incidentally found Meckel's diverticulum. Remember the most common neoplasm. The most common neoplasm in Meckel's diverticulum, it is not adenocarcinoma, it is the neuroendocrine. It is your neuroendocrine. Overall, most common is going to be the neuroendocrine. It's a neuroendocrine. Yep. So this is all that you should know in the context of Meckel's diverticulum as well as jejunal atresia. Limited bowel resection में you resect the end of the diverticulum with the bowel part also, then you anastomose these two. ठीक है, यहाँ से काटा और यहाँ पे जोड़ दिया. This is what we call it as limited bowel resection, right? So that's it for today. Thank you so much for joining on the BLS series. Tomorrow we'll continue with the small bowel. I'll talk about small bowel obstruction tomorrow, and then we'll take the story from there onwards, right? Thank you so much for watching. Take care. Bye. Good night.